Hello, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is 2026 Hospital Outpatient Prospective Payment System Final Rule. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the Q&A pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional comments and questions. Any questions posed during the webinar will be responded to via email after the webinar. We've posted a PDF copy of the presentation slides for your reference in the resources pane. You can customize your viewing experience by resizing, moving, or minimizing all of the panes within the webinar.net platform. With that, I would like to introduce today's presenters, Marty Ross and Kathy Reep, so they can talk turkey.
Thank you, Jennifer. We will try and avoid all of the Thanksgiving references, except before we get to the main course of the outpatient rule. You knew I'd do it. We'll have a few appetizers. We're going to talk about the end of the shutdown, specifically the Continuing Appropriations, Agricultural, Legislative Branch, Military Construction, and Veteran Affairs and Extensions Act of 2026.
You don't have an acronym for that?
It's called the minibus. That's what I've seen it referred to.
All right.
Yeah, as opposed to the omnibus bill. We will talk about that bill. We'll highlight the 2026 Medicare premiums and deductibles. And then, there we go, the OPPS Final Rule, and a dessert of end-stage renal disease prospective payment system. So again,
with a little bit of wording about home health.
A little bit on home
health. A little
bit.
bit.
A teaser, right?
A teaser. Oh, perfect.
There you go. Exactly. As you recall, we were set to do this webinar on last Wednesday, November 19th, but CMS had other ideas of not releasing the OPPS final rule until last Friday at 5:15 p.m. So we are recordings and then sending this out to you as a recording so you can watch as you get overwhelmed by football and food and what's tryptophan, right? If you need a tryptophan solution, isn't that the secret chemical in turkey that makes us tired?
Okay. Something like that.
Something like that.
But we also, if there are questions on this, we do want to get people to submit their questions anyway, even though it is a recorded webinar.
Absolutely. It works just like it does with the live webinar. You just submit them in the questions pane and we get back with you by email with any of those questions. So let's start with the minibus bill that passed early November 10, November 15? I can't remember. It all runs all over the place. But this is the legislation that ended the shutdown. And for the most part, it continued fiscal year 2025 funding through January 30 of 2026. But there are provisions in this legislation of particular concern to healthcare providers, and we'll focus on the retroactive extensions within the legislation. So great concern with the federal government shutdown on October 1 because we had a number of healthcare extenders that had terminated effective midnight September 30. And so we had a period between October 1 and the passage of this legislation where it was up in the air whether CMS was going to provide reimbursement or take other action during this period. And the good news is, the very good news is that, in fact, Congress extended these provisions retroactively back to October 1. The bad news is they only extended it through January 30 of 2026. But let's review quickly. Of course, top of the list is the COVID-19 era telehealth waivers now have been extended, meaning you can continue to provide medical telehealth services to individuals in their homes without regard to where they live. Remember, on a permanent basis, we now have coverage for telebehavioral health services. However, the requirement that you must first see the individual in person within 6 months of initiating the telehealth services, that was expected to come into effect on October 1, but CMS has extended the waiver of that particular provision with respect to telebehavioral health services. Also of note, though not part of this legislation, but certainly something we want to draw attention to, The DEA has posted its notice that it intends to publish the 4th temporary extension of the COVID-19 telemedicine flexibilities for the prescriptions of controlled medications. The current waiver is set to expire on December 31st, and DEA now intends, in fact, to extend out that waiver. It had a regulatory solution that did not go over very well. I think that's putting it mildly, but it will continue with this waiver of the requirement that there be an in-person visit in advance of prescribing controlled substances. Also extended were the Medicare dependent hospital and low volume hospital programs. CMS will not discontinue payments into those programs. The Community Health Center Fund, the Medicare physician fee schedule gypsy floor for those that live in areas where the wage index is below 1. That adjustment up to everyone at 1 will go back into effect till January 30. The rural ambulance add-on payment, the acute hospital care at home waiver is back into effect. And not a waiver, shall we say, but the continued delay in the Medicaid disproportionate share hospital payment reductions. As you'll recall, this goes all the way back to the Affordable Care Act, where Congress set in motion cuts to Medicaid DSH on the expectation of expanded coverage and no longer needing that additional money into hospitals. But Congress has been kicking the can down the road now for over a decade, and it now has just kicked it a little bit further to January 30. So where does that leave us in terms of processing and reprocessing claims for services that were rendered during the shutdown period? CMS has now officially instructed the MACs to perform mass adjustments to any paid claims that were inconsistent with the retroactive extension. So if, for example, if they had paid a claim submitted by a Medicare dependent hospital, it may have paid that at the regular PPS rate. It now should go back and make an adjustment so that additional payment would now be received. Providers that had submitted telehealth claims that were denied with the messages CARC16 or RCM77 should now resubmit those claims as they are now covered, though they weren't previously. Sort of the interesting piece of this is the acute hospital care at home waiver, because CMS had instructed hospitals that as of September 30, you needed to stop admitting new patients. And if you had patients that were on the waiver, they either needed to be discharged or they needed to be admitted into a facility. So interestingly, if you didn't follow those instructions and you continued to provide services, you now have the opportunity to submit the claim for those services furnished under the waiver. So we'll see where that goes. Maybe an interesting lesson learned if we find ourselves in shutdown mode again at the end of January. Kathy, you want to talk sequestration?
I love talking sequestration because I can pronounce it. This is, for those who are not familiar and always wonder what's she talking about. This is the rule that's been in effect for a number of years, that when Medicare owes you $1, they give you 98 cents. Well, based upon the language that or the analysis that was done by the Office of Management and Budget following OPPS, One Big Beautiful Bill Act, and the impact of that, they had indicated that we would need to increase sequestration from the current 2% to 4%. So rather than getting 98 cents, you'd get 96. Well, guess what? There was a particular provision in the minibus that basically said zero. The $3.4 trillion deficit that came about under the One Big Beautiful Bill does not exist. It is zero. And therefore, we will be able to keep sequestration at 2%. When I say zero, it means that the impact is zero. It does not mean that sequestration goes away. It stays at the 2%. So that was a surprise, I think, Marty, when we saw that in that rule.
It was, and it's like literally the last word of the minibus is zero.
Zero.
And what a power. Congress can just wipe out the deficit impact
$3.4 trillion.
Right. And so there will be no adjustment made to Medicare. What's mandatory spending? PAYGO requires mandatory spending. be reduced if a certain trigger is hit when the clock strikes midnight on the last day of the current legislative session. It will be zero. We never saw that $3.4 trillion impact to the deficit over 10 years. So there we have it. So what's ahead? Well, obviously, I've said January 30 how many times now? That's 66 days away, or 42 working days, given holidays and weekends. So Congress has to figure out how they're going to fund the remaining programs from January 31st through the end of the federal fiscal year on September 30. There are certain programs they permanently funded, such as the Ag Bill is permanent through September 30. But they have lots of other federal agencies that need to be funded. And then, of course, this issue of those healthcare extenders, those enhanced Medicare payments, also needs to be revisited, as well as the delay of the dish cuts. So are we likely to see another continuing resolution that will simply once again maintain FY 2025 spending levels for the remaining programs? Anyone's bet. The more interesting issue ahead on the legislative calendar is the promised vote on the extension of the ACA enhanced premium tax credits. So
although that was only promised in the Senate.
True, right. And that was the promise made by the Majority Leader Thune to the Democrats that crossed over and voted to end the shutdown, that they would get a vote on the ACA subsidies. That was the holdout. That's why Democrats were refusing to vote in favor of ending the shutdown, because they wanted a concession on the ACA tax credit extensions. They didn't get it, but they got a promise for a vote. We will see where that's headed. Of course, remember, absent the extension, CBO tells us about 4.8 million people are going to lose coverage. Millions more will pay significantly higher premiums. I had to break that to my 28-year-old son. Yes, dear, your premiums are going up. Exactly. Kind of hits home close there. Even though he never had subsidies, his rates are going to go up as a result of the end of the extensions. What was it? Earlier this week, President Trump said that he had a plan to come up with an extension, sort of a light version of the extension. That's now kind of been backpedaled, and so we will see what happens after the Thanksgiving holiday on this one. But shall we say, stay tuned. Okay, Kathy, main course. Oh, no, not main course.
No, not yet. No main course yet. Excuse me. Okay, forgive me, sensitive here. Out-of-pocket costs are going up for Medicare beneficiaries, and I can attest to that. The Part A deductible and co-insurance, both for the hospital services and skilled nursing facility services, will be increasing. The deductible for hospital services will go up from the current $1,676 to $1,736 for the first 60 days. And you can see on the slide the increases then for your daily co-insurance after day 60, and then for your lifetime reserve days. Again, all of them going up. Skilled nursing going up for the days 21 to 100 from the current $209.50 to $217 a day. So not only are we looking at individuals who are seeing an impact on the increase in the Part A deductible, but also under the Part B side, we are seeing a significant increase. Your Part B premium is typically paid through or taken out of your Social Security check. We're going to see that increase from the current $185 to almost $203 per month for the beneficiary. If you're in a Medicare Advantage plan, you might receive a premium rebate, usually less than $100. So you will see that increase even for the MA enrollees. CMS has stated, and Marty will talk in a little bit about payment for skin substitutes, but that if it had not been the change in payment for skin substitutes, we would have seen that Part B premium go up an additional $11. The annual deductible is increasing by about 10%, going up from the current $259 to $283. And we're also going to see an increase in your supplemental insurance rates both for Medicare Part for your supplement and for your Part D. Your Part D premiums are also going to go up significantly. So it becomes an issue for the enrollees as they see under Part supplemental plans increasing maybe $50 to $60. If I look at what has happened here in Florida, and the Part D premiums going up again another $40 or so. So recognize this will be some significant out-of-pocket obligations on the part of the beneficiaries, at least to maintain that supplemental insurance that then pays their co-insurance for the coverage. Marty, shall we do it? Get to the turkey?
Get to the turkey.
All right. Here we go. We knew that when we had a proposed rule, we were looking at some significant changes under the Medicare program. And a lot of these are still happening. Some of them are being delayed, but let's kind of walk through what we're looking at. First of all, we're going to wind up with a 2.6% increase to the base rate as published. It's not necessarily where we're really going to wind up, but let's look at that 2.6% increase. They had proposed 2.4, increasing our payment rates from the current $89.17 to $91.42. They based that 2.6% increase on a market basket increase of 3.3% less productivity of 0.7. And we're all familiar with the fact that if you are not, you do not meet the quality reporting requirements under the outpatient program, that there is a statutory 2 percentage point reduction off of that conversion factor as well. The outlier threshold is going to be reduced from 71.75 to 62.25, so significant reduction, close to $1,000 in the outpatient threshold, meaning that more cases will become outliers under the outpatient prospective payment system. The ambulatory surgical center conversion factor follows the same increase percentage that is used under the outpatient prospective payment system. We're going to see a payment rate of about $56.32. They are paid pretty much close to 61% of OPPS, again, with that statutory reduction for those not meeting the quality reporting requirements. This is the table that is published in the Federal Register that walks through the payment rate. Remember, a minute ago, I just said that the payment rate was going to be $91 and $91.41, 42 cents. Well, look at that bottom number as we go through the calculations. We are now looking at a number that's just barely not even $91. So we're looking at $90.97 for a final rate. How did that happen? Let's look into it. Remember that thing we talked about under the proposed rule related to the 340B remedy? The proposed rule has said that rather than reducing payment, well, let's go backwards a little bit. We had an adjustment to 340B a number of years ago where they reduced the payment for 340B drugs to average sales price minus 28.5%. To maintain budget neutrality, they increased the base rate, the conversion factor, for all providers going forward, whether or not you were in the 340B program or even eligible for the 340B program. In the proposed rule, they said that, the hospitals litigated that particular issue, saying that there was no basis for that number that CMS came up with in terms of the reduction. So what they were successful in court. CMS essentially lost because they could not support the amount of the reduction. The courts told the CMS to make the 340B hospitals whole for the dollars that had been reduced, but CMS took it upon themselves to impose second part of that remedy, although not mandated by the court. They said that we're going to take back those dollars that we put in your base rate for all providers. They originally said that they would do it at a 0.5% a year over 16 years. The proposed rule then came along and said that no, we're concerned about being able to actually get our money back. Therefore, we're proposing to do a 2% reduction over 6 years rather than a 0.5% over 6 years. There are a lot of comments on that particular provision. Providers and associations representing hospitals were very concerned about that 2% reduction over 6 years. I want to say you were successful, but I don't think we can say that yet. You have been successful for a year. Essentially, what CMS has said is that they will stay at a 0.5% for 2026 only. And that is where that conversion factor reduction comes into place. That brings us down to that $90.97. They did also say that that providers should anticipate more significant reductions up to 2%. Excuse me, up to 2% in calendar year 2027 and beyond. Essentially, this is a provision that CMS is saying, CMS is saying that we hear you in your comments saying that we are taking this and you did not give us enough time to budget for us with this being effective in calendar year 2026 and not getting a final rule. Back when they commented, they thought November 1. It turns out to be November 24, 25 that we get a rule. So now what they have said is we're telling you now, you are going to get a more significant reduction beginning in 2027. So recognize this is of a concern. As the footnote or the note does say on the slide, this is not applicable to hospitals that enrolled in Medicare after January 1 of 2018. So that's number one. We were successful, but it's not going to stay that same level of success, I do not believe, moving forward.
I guess the trade-off, Kathy, is we were all, we were expecting sequestration. So we were looking at reducing payments by 2% that way. So if sequestration is only going to stay at 2% instead of going up to 4%, so now we can budget in 2027.
Okay. That's a good offset. Yeah, okay, I like that.
There you go.
Meanwhile, we've got that inpatient only list. I think our proposed rules slide said deja vu all over again. And now it is rest in peace. The inpatient only list is going to begin a phase out again, as was originally addressed during the prior Trump administration. We are now looking at a similar phase out again over 3 years, beginning in calendar year 2026. They are going to remove 285 procedures from the inpatient only list, the majority of which are musculoskeletal. They are going to make sure that for those services that are provided on an inpatient basis, if they will be exempt from the 2-midnight review policy review unless over time it shows that more and more of these services are being provided in the outpatient setting. The same services, or the majority of them, those 285 that are being removed from the inpatient only list, are going to be added to the ambulatory surgical center covered procedures list. They are adding over 500 codes to the ASC covered procedures list, 271 of those that were removed from inpatient only, and another 289 codes that are really geared more under the issue of physician discretion as to where those services are provided. Keeping up with, let's go back to 340B, kind of. And this is a survey that, first of all, was called for under the executive order issued on April 15th, lowering drug prices by once again putting Americans first. The president basically indicated that the secretary was to publish a plan to conduct a survey to determine hospital acquisition costs for covered outpatient drugs at hospital outpatient departments. CMS has already sent out to hospitals information requesting contacts for this particular survey, who should receive it. They want to issue the survey in early calendar year 2026 and to use that data for 2027. There have been some national agencies or associations that have been hesitant to tell providers whether they should participate in the survey or not. They have pretty much said it's up to you, but CMS has now responded to these concerns, saying that they cannot force hospitals to complete the survey, but that they may consider non-responses and future rate reductions. That's a little bit scary, because does that mean my acquisition cost was zero if I didn't respond? I don't know. But concerning in terms of how they use non-responses in rate reductions moving forward. And I love the fact that they used rate reductions. Okay, they don't seem to be looking at the fact that this survey could say it should be an increase in payment amount, but no, they're definitely looking at payment reductions moving forward.
And I mean, take it to the logical conclusion, Kathy. They're doing a survey. They're going to cut 340B reimbursement.
Absolutely, absolutely.
That's where it's headed. So again, something else to budget for.
And recognize that they want to implement this in 2027 rule. Therefore, sometime next summer, you're going to find out what they're going to do beginning in January of 2027. So again, might be a good time to comment when we see that rule come out. Again, another provision that was proposed and CMS is moving forward with in terms of site neutral payments and as it relates to drug administration. For those drugs that are administered in an off-campus department, whether or not that off-campus department was grandfathered, i.e. in existence prior to November 2nd, 2015, all off-campus drug administration services are going to be reduced from a payment perspective. Currently, for those outpatient services that are paid under the physician fee schedule and equivalent to, they are actually reimbursed at 40% of the OPPS rate, because hospitals bill on a UB, physicians bill on a 1500. So the information that is presented is different. So the only way to actually equate to a hospital claim to a physician rate is to reduce the OPPS rate by a certain percentage. So that percentage will be a 40% of HOPD rate, reducing it by 60%. And this will, beginning in 2026, apply to all providers providing drug administration off campus other than rural sole community hospitals. And it is being done in a budget neutral manner. So it does increase the base rate a little bit for all services, even though there is over a significant decrease in the payment rate for these off-campus drug administration services. CMS, in their final rule, does respond to comments about whether or not this should be expanded to on-campus, and it is something that they will be looking at moving forward. So we're not free yet from having this applied on an on-campus basis. Marty?
Well, let's talk about what's actually another site-neutral policy, which is CMS's changes in the manner in which it will reimburse for skin substitutes. And if you put the OPPS rule side by side with the Medicare physician fee schedule rule, you see that CMS is now going to pay for skin substitutes consistently without regard to the location at which the service is provided. So historically, different payment methodologies within HOPD versus the physician fee schedule, but the driver was an average sales price based reimbursement for skin substitutes. In the OPPS scenario, that was a matter of unconditionally packaging skin substitute products that were furnished in an HOPD into the associated application procedure. So it was a single payment, but it was impacted, of course, by the cost of the skin substitute. There's incredibly wide variation in the sale price of skin substitutes, from $35 a centimeter up to $2,000 a centimeter. And CMS recognized that we had just an explosion in the costs for skin substitutes. And Kathy referenced that, the $11 increase in the premium, which would have been, the additional $11 increase in the Part B premium had CMS not taken action on skin substitutes. And can't hide from it. The net result of what CMS has done is a 90% reduction in reimbursement for skin substitutes beginning in 2026. Specifically, again, in the OPPS setting, that means that they will unpackage most skin substitute products and reimburse for them now under 3 newly established APCs, which are based on the regulation of the particular skin substitute. All 3 of those APCs, at least for 2026, are going to be reimbursed at a flat, standardized national rate of $127 a centimeter. And then there'll be a separate payment for the procedure that involved the application of the skin substitute. As a result of that action, there's HCPCS codes that will be that describe low-cost groupings are going to be deleted. The high-cost group HCPCS codes will be preserved to describe the application procedure and the reimbursement for the application procedure. There is a narrow exception to the $127 a centimeter rate. That is for products that are in fact licensed as biologics under Section 351 of the Public Health Services Act. This very narrow group of skin substitutes, because they are in fact meet the definition of biologics, they will continue to be reimbursed based on average sale price. So it's pretty straightforward what they're doing. But it's incredibly impactful. And we had clearly a heads up. This was in the proposed rule, both proposed rules, OPPS and Medicare Physician Fee Schedule. So hopefully if you have been budgeting for this change in 2026, it's going to be impactful in different ways to different types of providers. But certainly if you're cutting out 90% of the reimbursement, the goal here is to drive competition to more affordable skin substitutes. There are several that actually there'll be not a lot, but there are several that currently the price is below 127 a centimeter. So actually there's some potential savings there. The idea is to drive providers to those lower cost products and create more competition in the market. So big change there going forward. Briefly on the issue of virtual supervision, again, something that's been another one of these COVID-19 leftovers, as we had continual renewal of a waiver that permitted virtual supervision for purposes of certain services furnished in an OPPS setting to be provided virtually. So using one of these, handy dandy video audio connectivity. CMS has now decided to make permanent virtual supervision for cardiac rehab, intensive cardiac rehab, and pulmonary rehab services, as well as diagnostic services. Note, underline 3 times that audio connection alone is not sufficient. It needs to be real-time audio visual connectivity to meet the virtual supervision requirement. Also note that it does exclude diagnostic services with the global period indicator of 010 or 090. Those will continue to need to be in-person supervision for those services.
Price transparency is still with us. Just want to make sure that you're aware. We do have new requirements that are effective on January 1. However, CMS has graciously said that they will delay implementation until April 1. Isn't that April Fool's Day?
Yeah, and your birthday. It's enforcement, not an effective date. So
yes, if it's effective January 1, enforcement delayed. So let's kind of look at what the changes are. They pretty much have gone almost directly from what they proposed. As it CMS always uses the term charges when it refers to our negotiated rates. They are going to require an actual dollar amount to be reported when we're looking at rates that are based upon a percentage or an algorithm. Currently, we have been instructed prior to January 1 to have included an estimated allowed amount. They are now going to require on your machine readable file the reporting of the 10th, median, and 90th percentiles for all negotiated rates that are based upon a percentage or an algorithm for each and every payer. So you report payer 1's 10th percentage, 90th and median, payer 2, etc. They are going to require you to calculate and encode the actual count of the amounts of the allowed amounts. You're going to have to indicate how many claims you looked at and the actual result of that calculation. You're going to now be required to use the 835 electronic remittance advice or an alternative equivalent source of remittance data. I think we will see more on that posted through the GitHub as CMS provides more guidance. And I've started to see some guidance come through as of the last couple of days as well. The look back period in terms of going back and doing this calculation of your 10th, median, and 90th percentiles is no less than 12 months and no longer than 15 months prior to posting the machine readable file. I guess my question right now, and someone probably should put in the GitHub, is what happens if I just sign the contract and I do not have 12 months of claims data to do this analysis? What do I do then? To me, I have nothing that I can report other than an estimate, but I can't calculate a 10th, a median, and a 90th. But some way or other, we're going to need to have clarification, I think, from CMS on how we move forward with that. They are also going to require the encoding of the CEO, president, or senior official who oversees the reporting of this true, accurate, and complete price transparency data. They are going to require that you encode your type 2 national provider identifier. Are you reporting at a hospital level, or is this a hospital unit? So the particular charges could be tied to the acute care hospital. They could be tied to a distinct part rehab or psych unit. And so at those points, you need to make sure that you clarify on your files the taxonomy of the entity for whom you're reporting. They did finalize the 35% reduction to a civil monetary penalty if you waive your right to an ALJ hearing, if you're found to be in violation with the requirements for price transparency. However, they did come back and say, however, we will not apply this in all situations. So recognize that they will have some instances where you do not have that option to reduce your civil monetary penalty. One of the areas of key discussion when it came to the comments and the proposed rule was the attestation statement that was going to be required. This is the new attestation statement. And the words that I have in italics were the big issue. The original proposal started with the words, "This hospital has included all applicable." What the commenters asked for and were very vocal about, and CMS did respond to, was the inclusion of the words "to the best of its knowledge and belief," to make sure that it is clear that it is my belief that I've done this correctly, but I am not guaranteeing. So it's to the best of its knowledge and belief, this hospital has included all applicable standard charge information in accordance with the requirements, and the information encoded is true, accurate, and complete as of the date of the file, that you have included all payer negotiated charges in dollars that can be expressed as a dollar amount, and then it goes through that calculation process related to the 10th, median, and 90th percentile. So recognize that this is the key change from the proposed rule, and that is including those words "to the best of its knowledge and belief." Marty, you're the attorney on that one.
Oh, no. I have a lot agree, but not a
Okay, got it.
But I'm curious, is like, so this is the statement that needs to be signed by a hospital, a senior hospital official.
This is encoded in the machine readable file. And it is just, you're then going to type in on your machine readable file, you're going to type in this statement and then you're indicate true.
Okay, so that's
The other choice is false, but that's it.
well, false, and then it rejects your file. I know that
Exactly.
part. So this is the interesting question, Kathy. I don't sign this till April 1st, right? I wouldn't want to make this representation until April 1st. Or is that the deadline for making the representation or hitting the code?
That's the deadline for being that enforcement begins.
Okay. So but once I've updated my files to meet the
new
requirements.
This is one of the new requirements.
Okay.
It replaces your current attestation. The actual encoding of the CEO or other official is not actually a signature. It is the name and the status of that individual.
They're on the hook, as they say, right? So,
yeah.
And if I go back in and update my file, this is the other question I had for you, is if I go in to update my files per the new regulations, am I required at that point in time to update my files per any new negotiated rates? Or is that still, I only have to do that on an annual basis?
Your machine readable file, your rates need to be updated annually.
Right.
But if you are changing your methodology from the current estimated allowed amount, one number, to 3 numbers, 10th, median, and 90th, I think you're going to use more current information to do that, to get your minimum of 12 months look back.
Right. Okay. Yikes.
Particularly, I would think if you're using a vendor to do this, you're going to bring it as current as you can.
Right. Absolutely.
Quality reporting?
We always play with the outpatient quality reporting requirements, just like we do the inpatient quality reporting requirements. And again, this march toward the use of ECQMs continues, specifically beginning in the voluntary reporting period. There's a voluntary reporting period in 2027, becomes a mandatory reporting requirement in 2028, is the use of the ECQM for emergency care. Specifically, emergency care access and timeliness. So because we're going to the ECQM, CMS will retire the measures previously used, which are their median time from ED arrival to ED departure, as well as discharged ED patients left without being seen. So those 2 measures will sunset in 2028, and thus you'll do the ECQM. Interestingly, in 2027, you could report the ECQM because it's voluntary, effectively, to test, but you would also still have to report the other 2 measures because that's how the calculations will be made. So it's not a substitute. You have to do both for that time period. Additionally, CMS is removing certain measures from the outpatient quality reporting program, beginning with the 2024 reporting period and 2026 payment determination. They're removing the measure on COVID vaccination coverage or healthcare personnel. And you're like, well, wait, how are they removing something that's already been reported for 2024? What they're telling you is even though you reported that data for 2024, they're not going to include your score for purposes of calculating the payment determination in 2026. So if you didn't report, it's not going to hurt you in 2026 with a negative payment adjustment. And then beginning in 2025, so what's going to be reported this year, you will not be required to report on the hospital commitment to health equity, the screening for social drivers, or we're supposed to call them upstream drivers of health now, nor the screen positive rate. So those measures, though previously required, which would have been effective in 2025 for reporting period 2025, you will not be reporting that for 2025 and 2026. Those are our changes, actually relatively minor, although anytime you add an ECQM, it's certainly a heavier lift than any other type of the measures.
But Marty, wouldn't you say that for the SDOH, hospitals should at least continue to collect that both on inpatients and outpatients?
It is now a choice, right? Because it's not going to impact your inpatient or outpatient quality scores.
But it does impact your coding on inpatients.
Right. Because remember, the Z code for homelessness still is going to impact your reimbursement on the DRGs because it will go from a non-CC to a CC rate. So that significantly increases your reimbursement on those codes if you've appropriately captured the Z code for homelessness, which of course you would need to be doing some sort of screening to have collected that information in the record. So it's sort of do we continue doing this? Do we find it helpful? Is it important to our inpatient reimbursement? Is it worth the lift? And at this point, most hospitals have created the processes to collect that data. But at the end of the day, it's no longer going to be impacting your quality scores or your ability, your way avoiding the 2% negative adjustment. Star rating methodology changes. This always sort of ends up in the OPPS rule, but why not? So this is the Medicare Advantage plans. No, it's not. Why did I say that, Kathy? I was thinking I had Medicare Advantage stars in my brain. I don't know. This is the Care Compare.
Medicare Advantage are stars to you? Never mind.
No, well, they have star ratings, but this is the hospital.
Know.
It's the Care Compare now. It's not Hospital Compare, it's Care Compare. For 2026 only, there'll be a cap on 4 stars for any hospital that is in the lowest quartile of safety of care measure group performance. So if you are absolutely outstanding on all the other measures, but you don't do well on the safety of care measures, you're capped at 4 stars. Even if it would otherwise earn you a 5-star rating, you're capped at 4 stars. Then beginning in 2027, there'll be a 1-star reduction for hospitals that end up in that lowest quartile for safety of care. Of course, if you're already a 1-star hospital, you're not going to become a 0-star hospital. You'll just stay a 1-star hospital. But you'll have, if you would have otherwise been a 3 and you're in that lower quartile, you're going to become a 2-star hospital. And the hospitals that have fewer than 3 safety of care measures, they only have data to report on 3 of them, or they only have data to report on 1 or 2 of the measures, they're going to be exempt from the star rating adjustment. Kathy, ESRD?
Let's take a look at the ESRD final rule. We received that prior to the outpatient rule, and Marty and I thought they were all going to drop at the same time, and we were going to get a number of rules, but no, kind of piecemealed them out. So very quickly on the end-stage renal disease final rule for calendar year 2026, we are looking at a 2.2% increase in the base rate, going from the current 273.82 to 281.71. So almost an $9 increase in the rates. The outlier fixed dollar loss threshold and the Medicare allowable payment amounts are provided on the slide for pediatric beneficiaries and for adult beneficiaries. You can see that those the fixed dollar amount, this is considered your outlier threshold, are decreased for both the pediatric patients and the adult patients, as is the Medicare allowable payment amount. Those are all decreased from current year. And the facility level adjustments, there is a new facility level adjustment for providers in Alaska, Hawaii, and the U.S. Pacific territories to address higher non-labor costs when compared to contiguous U.S. This is not an adjustment to, this is addressing non-labor, not labor. Labor would be addressed through your wage index, but this is going to be a facility level adjustment that will be, just as it says, specific to an individual provider within a particular location. So something interesting to for the providers in these non-contiguous areas of the continental United States. So
why here and not elsewhere? Why only in this rule for this adjustment?
I agree. But I wonder if it's going to carry forward.
It's really interesting. That adjusts, and I get it. I mean, I'm sure everything is far more expensive, but why here for ESRD providers and not for every other?
Absolutely.
Have it.
And then, sorry. There you go.
Okay. Are you good? Oh, okay. Quality. Again, ESRD program, quality incentive payment program, relatively minor changes for performance year 2027. They're removing the same measures that had been previously added. Again, facility equipment, commitment to equity, screening, and screen positive rate. Also, there's an update in the in-center hemodialysis CAPS clinical measure. So this is the survey, the patient satisfaction survey.
Right.
It's an incredible 62 questions. It's like, wow, who can you keep on the phone for 62 questions. But they're now taking.
And is the last question on the survey, did you have any problems completing this? No, never mind.
Exactly, probably. But so they're reducing.
It's only going to be 39. Wow.
Yeah, it's like a fraction of that for other providers, but I guess that's probably the increased higher cost anyway. But that's where we are on the ESRD quality payment program. Now, Kathy, you want to talk about home health?
I wish I had something to say. Those of you who operate either a freestanding home health agency or a hospital-owned home health agency know that the proposed rule called for a 6.4% decrease in the rates. Recognize we don't have a rule yet. It is sitting at the Office of Management and Budget. We don't know why this is so significantly delayed. The issue is if they were to publish it today, and they won't because I don't believe, it doesn't look like it's sitting, it's been dropped yet. The question is, when will it be effective? Will they provide a significant change in this particular rule and have it effective January 1? We don't know, but Marty and I are going to keep an eye out for this rule to be published, and we're going to make sure that we get some, probably not a webinar, but at least a little communications out to you in terms of what's going on with home health.
Kathy, there's like, is it like 25 rules now sitting at OMB from CMS? It's the highest, I think. It was higher before these rules came out, but it's like, I've never seen it this high.
Well, and I the other day it was 31. And so now I think it's down to like 27, 28, something like that. It's huge.
It's huge. And it's like, I mean, sort of what we expect, right? Because the MA rules are sitting there, and we typically see those at the end of December. The payment rule for 2027 comes out at the end of December, starts the process for MA. But there are CMS Innovation Center rules. There are Medicaid policy rules. There's just so much sitting there.
Transparency and coverage, which would be the transparency rule for the payers. That's sitting out there.
So never a dull moment. And I guess the rule of reducing regulations doesn't apply when you talk about Medicare and Medicaid, right? So payment policy will continue to move forward. On that note, we will start our two-part series on the Medicare physician fee schedule, which actually came out on October 31st at 5 p.m., right? As the kiddies were headed off to trick or treat. We'll do this in two parts on December 3rd, so next Wednesday, and then December 10th, the following Wednesday. You see the registration information for those two webinars. We'll go even deeper into skin substitutes because that's, again, that neutral policy that they've adopted across all provider settings. So otherwise, thank you for joining us. Sorry for the delay, and have a lovely Thanksgiving holiday.
Enjoy.
Thanks to our presenters, Marty and Kathy. Please remember to stay on the line once the webinar disconnects to complete a short survey. The slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available in the Thought Leadership section of PYA's website, pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete the short survey and post any additional questions you may have. On behalf of PYA, thank you for joining us. Have a great rest of your day.